So I am pleased to welcome you all to the 2025 Ann Ottney Cain Lecture in Psychiatric Mental Health Nursing. Dr. Ann Ottney Cain was Professor Emerita at the University of Maryland School of Nursing and a leader in psychiatric mental health nursing whose tenure at UMSON spanned more than 3 decades. When she retired from the School of Nursing in 1994, the faculty, her colleagues, and students came together to create the Ann Ottney Cain Endowed Lecture in Psychiatric Nursing. Dr. Cain included the fund in her estate plans, a gift that has continued to fuel her legacy since she passed away in 2020. Today, friends, family, former students, and colleagues all continue to honor Dr. Cain and her commitment to psychiatric mental health by supporting this lecture. We are very honored today to have Dr. Cain's son, Jeff, and his daughter, Stephanie Cain, joining us virtually. Welcome and thank you, and let's take a moment to give them a round of applause. I'm very excited to welcome our distinguished speaker for this year's lecture, Dr. Wolbert Burgess, a trailblazer in forensic and psychiatric nursing and a globally recognized expert on the psychological impact of trauma. Dr. Burgess co-founded one of the nation's first hospital-based crisis counseling programs in Boston and went on to collaborate with the FBI to study serial offenders, shaping modern understanding of victim trauma and criminal behavior. Admittedly, I am such a fan of Dr. Burgess, I probably don't even need to read her bio. I could probably recite it largely from memory. Because her work speaks for itself and she's been someone that I've admired for quite a long time. She has been named an American Academy of Nursing Living Legend, inducted into the Sigma Nurse Researcher Hall of Fame, and is the recipient of the ANA Hildegard Peplau Award. Dr. Burgess holds her BSN and Doctor of Nursing Science from Boston University and is a proud University of Maryland School of Nursing alumna, earning her master's here in 1959. In September, she was honored as the school's highest award and named as a visionary pioneer for the University of Maryland School of Nursing. Dr. Burgess, thank you very much for joining us today.
Thank you very much. I appreciate that, and I'm delighted to do the Ann Cain memorial service for her because she was a wonderful colleague and we did much of the psychiatric work. She was just a leader in the field, and I'm so glad that we're able to keep her work alive. I wanted today, when I tried to think about what to talk about today for the symposium, we had done this work. Actually, it's only been about a year, and we had written it up and had submitted it for publication. Obviously, didn't know if it was going to be approved, but it has been, and it actually just came out last week. So for those of you who are interested in the actual publication in Nursing Outlook, you can go online and get it. I think you're able to download it. It's already been picked up by national I forget, several of the news outlets have picked it up. So what this whole active shooter issue has become a huge, huge problem. I know when I did my work with the behavioral science unit down at the FBI Academy, we were interested in serial killers. This is one person that would target one, usually just one, possibly two victims and kill them. And they were usually a sexual assault plus a rape plus the murder. That has declined. The number of serial killers has clearly declined, which is good. We're happy for that. But in its place, we see this actor shooter. It is one person going after multiple victims and is very, very dangerous, obviously very dangerous, but it represents a different type of person. So we're actively looking at that and to compare that with what makes the difference. I do know that when we were studying Ed Kemper and had an opportunity to talk to him, who is still alive, by the way, out in California in prison, that he said that he had to turn himself in. That's how he was caught. He called and said, he just had killed his mother and her best friend, and had to tell the police that they could find their bodies back in her apartment. But in that conversation, he also said later to the agents that he was really getting concerned because he was thinking of going on and killing multiple people. So he had started to escalate now. at least in his thoughts, to move from just killing one or two persons to becoming a mass shooter. So we're very good. We were able to stop him and to hear about him. And as I said, he's still alive and is being seen. There's going to be a documentary on him by a journalist who has really dug down deep into the issues and trying to find out what activated his whole thinking process and so forth. So it's going to be really, really good when that comes out. But back to the topic for today on active shooters, and I will the active shooter incidence, as I've already said, has increased. That active shooter incidence in healthcare settings has increased by 63% within about a decade, as of the latest on that. More of the focus has been on educational settings in the schools, of the active shooter in the schools. But it has spanned out to malls, to churches, and as we are concerned from being in healthcare ourselves and nursing, we are interested in what are we doing in our own discipline, the healthcare organizations. So emergency preparedness drills have become standard practice. And I was in doing the research or the background research, I found this article in the New England Journal of Medicine that was written by a pediatrician and a pediatric nurse. And it was very interesting that it started out saying empowered or traumatized. They call for evidence-informed armed assailant drills. It's not active shooter. They use the word armed assailant drills in U.S. schools. And the opening quote is, and I'll read it, "I was working in my preschool health office when the loudspeaker came on. But this time it was not the voice of a school principal. It was the sound of gunshots. I had no students in my office, so I locked the door, covered the glass, closed the blinds, and hid in a corner. I had no idea if this was an unannounced lockdown drill or an active shooter in our building. In the end, luckily, it was a drill, an unannounced one. The person running the drill had used an app on her phone that sounded like gunshots, which she played over the loudspeaker." And this article goes on, which was done 2 years ago, to say we really don't have much research on it. We do know that these programs were first introduced in the late 1990s, so we're really over a quarter, 25, 30 years now into this whole problem. And now, if you look at their statistics, Department of Education, 96.2, that's almost 100% of U.S. schools have used some sort of written plan to prepare for the possibility. And 40 states currently mandate active shooter preparedness. You certainly should, whatever state you're from, certainly Maryland or adjoining states, see what is going on, if you will, in your own agency. I looked up the FBI stats for 2025. They only had the 2024, obviously. And now they had said they had a decrease, which is good, but they still had 24 active shooter incidents in the year 2024. It occurred in 19 states. Of the 106 victims, 23 died and 83 were wounded. So this is still going on. It's still a major, major concern. What about Joint Commission? How are some of the big agencies getting involved? And they have put out a statement that they require healthcare organizations to actually conduct emergency preparedness exercise that would test communication systems, coordination with the local emergency response agencies, and what is the staff capability. So all of these are intended to enhance organizational readiness while building confidence and competence in emergency response procedures. That is the goal, of course. And so where do nurses come in? Well, we as nurses have a central role. We are frontline responders to balance patient protection with their own safety during crisis situations. We also have an ethical obligation through our ethical code to provide care during emergencies while trying to minimize personal safety or maximize personal safety and organizational support. What do we do in emergency preparedness? Well, we typically focus on how to get out, evacuation procedure, obviously communication protocols, and coordination with security and emergency response. All of those sound good, so let's see if they actually are put into place. There also is the psychological impact that we are primarily a group for psychiatric nursing. We are very concerned with workplace violence and know that it does create exposure to anything that creates exposure to violent incidents is going to contribute to post-trauma stress disorder, job dissatisfaction, and increased turnover rates among nursing. Huge impact psychologically. So we need to be prepared, although we need to understand that. So some of the workplace stress systems, some of you may work with patients or who have some of this. They report hypervigilance, sleep disturbance, decreased job performance. All of these, of course, we know can follow traumatic incidents. The workplace trauma note traumatized workers also have decreased empathy, have increased medical errors, and it compromises therapeutic relationships. So it's a huge impact, if you will, if there is workplace violence. So what about the drills? They can become sources of workplace stress if poorly planned or executed without consideration of psychological principles. Now, that has been put into literature, but it hasn't been tested. So that's why I'm bringing you an opportunity we had to actually study a situation. This is just a good, if you go into the literature, you will find all kinds of media photos of how they are preparing. Happens to be a classroom out of Scranton High School where the teachers are barricading a door as a way to prepare for an active shooter drill. And if we have time today, I do have one of the FBI drills that we can watch and kind of critique, see what we think of it. I hope we have time to do that. So in all of the literature preparing for a background on this study that we did, they warn about the negative impact of the drill. And they say that there is federal acknowledgement of the potential negative impacts that these drills have, so that it isn't just that you're supposed to do the drill, but you have to be aware that these drills can create trauma and have negative impact. A National Academy report emphasized the, quote, first do no harm principle, noting remarkable little evidence to guide drill implementation, while research suggests participants report negative emotional responses. And even as if that isn't enough, pediatric healthcare settings present unique preparedness consideration because child patients are so vulnerable and they have to have specialized trauma-informed care. So we had this opportunity to do the research that I'm going to tell you on, but there was really limited research as to how to deal with any traumatic experiences and need to develop approaches that enhance both the physical and the psychological safety in healthcare incidents. So here is, we could have called this the crisis that wasn't. We're going to tell you about a setting in a pediatric psychiatric facility that provided inpatient behavioral health care for children and adolescents. I will show you a little clip. It is now online. All of this has been exposed and online so that the public can be informed, so I can inform you of actually where it was and so forth. The incident was an unannounced active shooter drill conducted without proper notification to staff, patients, or emergency services. The reality of this incident was staff believed they were experiencing an actual life-threatening emergency, triggering genuine crisis response. So that's what we're going to talk about today. It is a qualitative descriptive study. Its purpose was to look at healthcare staff experiences following an inappropriately created active shooter drill at a healthcare facility, specifically a pediatric healthcare facility. Our research question was, and my colleagues Victor Petreka and Joanne Barros, they are both affiliated with Boston College. I, of course, be from Boston College, and this is we worked on how to healthcare workers describe their responses following this organizational induced traumatic emergency preparedness event. And the study aimed to identify how these measures could be improved to enhance safety while protecting staff psychological well-being. Okay, so how did this all happen? Just to quickly review over the PA system back at the Hawthorne Center, they told this front desk clerical worker that she had to make this announcement and to sound genuinely afraid. And so on, this is just before Christmas at 10 a.m., the call goes out that there were active intruders in the building. And they even did a second frantic announcement that said two intruders, one Caucasian male, one African American male, armed with AR-15s shots were fired. So it wasn't just the announcement, but also these two staff members were told they had to carry these guns and go around. As you can imagine, this also added, if you will, to their reaction. So I think we can say that the drill lacked adequate notification. Participants thought it was active, a large-scale emergency. Everybody came into being. So what was the study we did and how did we get involved in it? There were 88 healthcare staff members, and there obviously was the Michigan Department of Health and Human Services was found at fault and was charged with a very large amount of money that had to be allocated to the healthcare workers and the children. And so we being the Victor Petreka and Joanne Barros and I were called in to do the evaluation because there were different symptoms. There were some that were mild symptoms, there were some with no symptoms, some with mild symptoms, some with severe symptoms. So how would we allocate the persons, these 88 persons? And so that's what our job was. We had nurses and mental health techs, social workers, psychiatrists, teachers, and support. And we used the technique, the study of let's see, let me say, we originally had forensic evaluators collect statements about 6 to 8 months following the legal proceedings, and that's what we evaluated to come up with an algorithm to determine the impact that they had on each of the staff. We would do the secondary analysis. This study is the result of secondary analysis, and the attorneys had agreed that we could do the research component of the settlement. So that's what we wanted to do, to see how a totally unannounced drill, how it affected these 88 healthcare. So our sample was largest group being child care workers and mental health techs, 20%, teachers and education staff, almost 20%, and administrative staff a little over 13%. We had participants age in range from 18 to 74 years, with the majority 28.4% between that age. Most participants were female, identified as white, 55% black, was about a third, and about a third. And educational attainment varied. We had a bachelor's degree, about a third, followed by master's degree, about a quarter, and doctoral. So we had a wide, fairly educated group. And so we used the themes. We broke down the themes into 5 themes, and I'm going to go through and give you some of the examples. Primarily the first theme of organizational chaos and communication breakdown. I mean, that almost goes without saying that would be the major theme. It was incredible that management failed to understand the dynamics of anxiety and stress activated in the shootings. And here they are, a psychiatric facility, and they really did not understand it. Staff were required to process this whole experience they were going through without any guidance or acknowledgement of this. Now, this went on and you can even, it was timed to be about an hour, is that this was in effect. So not only do you have these 88 people from different backgrounds, but you have the 1 hour that they had to experience this before understanding that it was a drill rather than an active shooter. So what did the staff do? Well, they did tell us that nearly 200 workers and 50 patients barricaded themselves into place with no windows, stacked heavy furniture against doors, and armed themselves. And the children had to do it on their own, whatever they could find. Employees text or called friends and family members. They thought they were going to die. They told them that they loved them. As we've already said, 2 males just were ordered to walk through the entirety of building, checking to be sure every room was locked, everyone was hidden and barricaded, as if for an active intruder drill. However, both police and dispatchers didn't even know that the threat wasn't real. So you have them all responding with 50 of them, cars responded in full riot gear and guns to the hospital. So here's some of the quotes. After the incident, nothing immediately happened. Everyone was still trying to determine whether it was real or fake. About an hour after the drill was cleared, management made rounds and covered up what just took place. They gave us vague excuses as to what happened. They didn't offer any apologies or support. The organization response was defensive. Some staff were criticized for their emotional reaction instead of receiving any kind of assistance. This pattern of blame rather than support certainly aggravated the initial trauma and created additional stress. Here's another quote. Directly after the incident, we were expected to proceed with work as if nothing had happened. I was in shock and shaken up. I wanted to go home. I called my therapist and had to arrange an emergency session. I felt I was gaslighted into staying at work because the person that called said that we were babies and weak. Another quote is supervisors who were aware of the drill's nature deliberately withheld information to allow the staff to think they were having a real emergency. And this decision really represented a fundamental breach of trust, lasting implications for staff relationship. Here's the quote. I confronted a manager and my supervisor, asking them both why we were not told that this was a drill. And they responded back stating they were told they were not allowed to share that information. So there you have the upper management siding, of course, with full management and not going to in any way explain anything to the staff taking care of the patients. Now, the second theme was immediate physical and emotional crisis response. This was both staff had both physical and psychological symptoms. The intensity and scope of these reactions really showed the realistic nature of the perceived threat and the participants' belief that they were facing danger. Quote, directly after the incident, I was still crying and shaking. I was numb. I had chest pain. My shift, they did not allow me to go home. I was unable to communicate. I was in distress that night. I was unable to sleep. And if you remember when you saw the role play back of it, the one woman that was whispering, she didn't even know where she was. She was whispering and terrified that the shooter was still out there. So here are you have the physical symptoms. You had panic attacks, chest pain, cardiovascular symptoms requiring medical intervention. You certainly had the emotional response of uncontrollable sobbing, numbness, inability to communicate effectively, and you had staff contacting family members to say their final goodbyes. This is a very acute physical and emotional crisis. The panic attacks, all of these, here is one of the quotes. During and following the incident, I had severe panic attack and felt like I was going to die. I was hugging my colleagues and uncontrollably sobbing. At one point following the incident, I fell on my knees and two colleagues had to pick me up. So you had really serious immediate crisis panic attacks. They called family. This was underscored by their reports of contacting family members, saying goodbye, final sentiments. Here's one quote: I was texting my children and told them what was happening. I told them that I loved them, that if I did not make it out of the building alive, I was in tears as I saw the police outside and was sure I might not make it out alive. So they could look out their windows and see the police that were in full riot gear with their guns. What was the third theme? The third out of five: expectations to continue with no with full pop operations. They were expected to resume normal work without accommodating for their emotional state or processing needs. This expectation was particularly problematic given that these were staff who had professional obligation to provide care for pediatric psychiatric patients, who obviously themselves were traumatized by the incident. Quote, we were told we had to finish our shift. After our shift, the hospital people were said that we could come in and debrief in the conference room with them. That was the most that they were going to give them. So it was a dual burden for the staff. They had to provide patient care while processing their own trauma. They were expected to function professionally despite their compromised emotional state. So this dual burden of personal trauma, professional responsibility just intensified the psychological impact of the incident. Quote, we were expected to continue our jobs as if nothing happened. We were told to go on the units, to check our patients. There was no debriefing for us. The clinical staff had to go right away and check on our patients. Forced to continue despite the trauma. Immediate return, go back, finish your shifts. Patient care, they expected to comfort the traumatized by pricing their own, and no support was provided. What about the children? They had to describe the additional stress of having to comfort and care for traumatized children. They felt prepared to prepared the vulnerable children, as one participant said, in quote, most patients were panicked and scared as they were tearful, kept asking me if the alert was a drill or was real, kept asking me for reassurance that they were safe. I worked extremely hard to keep myself together so I could be supportive to the patients. And what these staff had to do, we armed these little children with combs and brushes and anything we could find to give them a fighting chance. So that they did try, but that was the most they could find, combs and brushes, to fight against drills, fight against guns. Fourth theme, development of post-traumatic stress and long-term mental health impacts. Some participants, the staff, developed symptoms that persisted for months. Don't forget, we got these comments that they had to write 6 to 8 months later, so that would qualify them in some cases to fall into the long-term post-traumatic stress. Here's one quote. I was diagnosed with acute PTSD. I have difficulty being around children, loud noises, and children now. This has caused me issues with my own family and personal life. I'll never be the same person after this damage. These extended, as we said, into their personal lives. Hypervigilance, avoidance behaviors, intrusive thoughts became persistent in the daily life for many of these participants. Quote, I was depressed, anxious, and traumatized after that incident, and I started thinking about death many times a day. I was getting flashbacks in the grocery store and outside afraid that somebody could come and shoot me. I don't go to grocery stores and malls anymore. So you have seen that person's extended trauma symptoms into other aspects of her life. So for career professional disruption, the quote is, I went from having a job I loved and hoped to retire from to feeling totally unvalued and unsupported by administration. And I will soon leave as soon as I find a position elsewhere. So you have the immediate impact, They sometimes exhausted their sleep leave so that they just couldn't function in the workplace. You had job changes, you have lost trust, and of course, you have ongoing fear. There are many career challenges from this one incident. Quote, since that incident, I felt extremely distressed every time I stepped foot in that building. I have to leave my job and work elsewhere, but I couldn't I wanted to do that, but I couldn't because I was an intern and had gone through an elaborate formal match process just to get this experience. So the financial burden of seeking mental health treatment represented additional costs, consequence of organizational failure with participants paying personal costs for professional therapy and medication management necessitated by this workplace trauma. And then the last theme, fundamental changes in professional practice and career decisions. This incident produced lasting alterations in participants' professional trajectory, their workplace relationships, and career satisfaction. These changes reflected a fundamental breach of trust between healthcare workers and their employing organization that could not be easily replicated. Quote, I had to switch jobs because of this to a facility that's now 45 minutes away. So the added stress, as I already said, they exhausted their sick leave. Participants said, I used most of my sick time because I was afraid to go back to work. It altered relationships with the workplace and career aspirations so that it affected far more than just personal stress. So long-term mental health, what was it? 8 months later, 88 staff were affected. PTSD diagnosis, clinically significant trauma symptoms requiring professional intervention. Daily functioning was affected, hypervigilance, avoidance behaviors, intrusive thoughts, and of course, financial burden. The unsupported aspect was overwhelming. Quote, I went from having a job I loved and hoped to retire from to totally feeling unvalued and unsupported. I'll leave as soon as I find a new position. And then another quote is, I never felt safe within that building again. I was constantly thinking about about the intake and where I would hide if a shooter were to enter the building. So you have the dynamics of shame, of blame, I'm sorry. You have the dynamics of blame and social isolation. They even had reaction from colleagues. Quote, I started getting treated badly during this time by other coworkers. Many believed it was my fault, and why they are going to be investigations on what caused the incident. They had countless sleepless nights and wanting to quit. This reveals that a mishandled active shooter drill could create significant and lasting trauma to healthcare workers. That the immediate organizational response is characterized by dysfunction and defensive positioning by the administrative staff involved. They felt they were facing possible death. They had continued death thoughts. And this distinction is critical for understanding both the severity of the trauma and the appropriateness of applying workplace violence research to these findings. And this brings us back to first, do no harm. And the implications for healthcare leadership. So all of you that are in a agency, to take careful note that you have to have trauma-informed preparedness, to integrate psychological safety principles into any emergency planning and training. There's a need to have clear communication, and you have to provide post-incident support to remind us of first, do no harm. So there are policy implications. Poorly designed preparedness activities erode trust, destabilize teams, and cause the very trauma they're intending to prevent. Leadership decisions are not merely operational, they carry clinical consequences. These are important implications for organizational accountability. You cannot determine whether leadership decisions reflected willful disregard for staff well-being or knowledge deficits about trauma-informed approaches. We didn't know that. We weren't able to study that. Did the staff, the administrative staff, just not know this? It just seems mind-boggling that they couldn't know it. But both scenarios represent failures requiring different remedy responses. Ethical violations demand disciplinary action. Well, they had serious discipline action. They closed the whole agency and had to move the children to an adult facility. So we don't know whether there were any other disciplinary actions because this was a very expensive undertaking. The sustained impacts on professional practice and well-being, we certainly, I think, have demonstrated that. And the findings, our findings, align with research demonstrating other healthcare workers exposed to workplace violence. PT rates range in this population from 7 to 37%, which is significantly higher than the general population. The other important thing is organizational betrayal trauma. There is research on organizational betrayal trauma, which demonstrates that you can cause more harm by trying to cover over or not deal with an incident. Judge in this case, I quote from a public source, said that a judge approved a $13 million settlement in this lawsuit over an unannounced shooter drill at this particular hospital for children, an event, he wrote, that terrified the staff and patients and caused them to scramble for cover, text family, and urgently call 911. So a finding that management attempted to cover up what just took place reflects certainly organizational defensiveness and it was pretty expensive to have to follow through with that. So studies indicate that inadequate organizational response leads to and can predict, and it's certainly in this case, the development of chronic PTSD symptoms and poor recovery outcomes. So what is the takeaway from this for nursing practice, for policy, for education and research? It certainly, in our opinion, highlights an urgent leadership and policy imperative. Healthcare organizations must integrate psychological safety in every phase of their emergency preparedness plans. Nurse leaders, executives, and policymakers share accountability for ensuring that there is follow-up trauma-informed principles, providing clear communication and structured post-incident support.
First, before you go to questions, to thank you, Dr. Burgess, for that, and for Dr. Burgess and everyone bearing with us through some of our technical difficulties. Even, 5 years post-COVID, we haven't mastered everything with all the sharing and Zoom and audio, but I think we still got the impact of the video. So thank you so much.
Okay, I'm happy to do a question or two.
Yes, I would love to know if anyone in the audience here has a question for Dr. Burgess. Okay. And Dr. Burgess, can you hear me?
Yes, I can hear you.
Hi, Dr. Burgess. I was wondering, when you mentioned the lawsuit at the end, was there any risk of that impacting the responses from victims, subjects?
Right. I got most of that. Was there anything from the our subject, you mean from our sample?
One of the subjects said, "I'll never be the same." And
yes, right.
Was that affected by the lawsuit?
Well, that's a wonderful question. See, I would love to know that. How many, like now, what is it, 3 years later, felt that the financial compensation made a difference? My hunch is if you look at how many changed jobs, they wouldn't even stay. That's a pretty to make that kind of a decision says a lot. I'm sure that as any traumatic event would be, it's always going to be in their head at some level, especially what would trigger that. There's a lot in the everyday activities that can trigger that. Remember the one that said the grocery store? Even doesn't go to grocery stores anymore. Also, the problem is this active shooter is in the news a lot. Anytime there is one, that's a lot of coverage, so that would bring it all back. So my hypothesis would be that she is changed. The one that said I am changed, she is changed, but it doesn't have to be for a negative. She is going to be changed in terms of being super alert to safety. The type of trauma that people experience has the capacity to push them into being much more safety conscious, if you will. The avoidant response is the primary response you get from any traumatic event. You just want to avoid any reminder. Did that answer your question?
Yes, thank you.
Okay.
Other questions? Dr. Parks.
Thank you for your presentation, Dr. Burgess. I'm just
Oh.
curious, I know this wasn't part of your study, but after all the discussion that you've had with your colleagues, is there anything that you think the organization could have done immediately after making so many missteps that might have helped the participants to be able to manage their trauma more effectively?
That's a great question too. What could, I guess we should say, what could upper administration have done that day afterwards? Should they have had some kind of immediate meeting, virtual meeting? Maybe I don't know how 88 people, that's a lot of people, and they have the children. See, this type of response causes more problems for them. They had to move all the children. They had to deal with, these were all state facility. It must have created an enormous aftermath of activity. But could they have immediately have done something? Yes. Why didn't they immediately go on the PA system and admit they were wrong? It seems as though organizations are so afraid to admit that they had done something wrong. Do you think, maybe I put it back to the group, would that have made a difference? Have any of us ever been in a situation where something went terribly wrong? But if the person was able to admit it and to say, we've got to work towards fixing it, whatever that means, would that have made a difference? Would that have neutralized some of the post-trauma symptoms? It really is something for administration to talk about. It doesn't have to be this kind of a situation, but just in general, when they do something, that whole organizational betrayal issue is huge. And I've run into it a lot, especially when they want to. I can just give you these big sexual assault problems, like Larry Nasser, and the that comes to mind, and the whole sports industry failed to make any kind of apology or acknowledgement of his behavior. So in this case, would that have made a difference? I don't know. I'd love to see it. That would have been interesting to see if anyone tried to do anything. See, we didn't have any access to information. I'd love to go back and maybe meet with a group to answer that question, and what did make a difference, and how many did anyone stay with Hawthorne afterwards? Did they all leave? I don't know.
I'm thinking maybe we have a follow-up collaboration between Dr. Parks and Dr. Burgess to investigate that question.
No. But wasn't it interesting when this just kind of fell into our laps, that we had this opportunity, and I said to Victor, we have to follow up on this. This is, And luckily the lawyers, this was a case where the lawyers agreed that we should get the information out to the field. So I'm delighted that Nursing Outlook took this on and published it. So please, it's a good paper. I think it's a good paper to have our nursing colleagues have a look at it.
Thank you. I think we have time for about maybe one more question.
Okay.
Anyone? Don't lose your chance. Okay.
Ask them how many do active shooter preparedness. Are they doing it in their agencies?
Everyone's nodding their head, yeah.
Yeah, I make our students, I feel I have to show in my classes, I show the FBI one. Even if there are a lot of things to critique it on, but it puts it in people's head that when something happens, you have to, it gives you something to think about, how to hide, how to run, how to run, how to hide, and then how to fight.
Thank you, Dr. Burgess. We do have, excuse me, an additional question here from Dr. Camilla.
Okay.
We actually met when you were recognized as one of the luminaries at the table that evening. So it's good to see you again. Here's my statement, and I shared this with the dean just a minute ago. I'm retired military. We practice and we train so that we get it right the first time. I get that the organization should have shared this information. But if there's an active shooter drill, if there's an active shooter, you don't get a chance to try to redo it and tell people, oh, go back to your stations so that we can do this again. And train sometimes, it's what keeps people safe if and when it actually happens. So I know there's a better way to do it. But it is something that we do have to do. I worked at an organization that did not do active shooter drills. And the staff didn't want to do active shooter drills. And this was a college. And the concern was, you all won't know what to do. I'm gonna make it out of here alive. I counted the steps to the exit. I know what to do. I want to make sure that everybody knows what to do. So I do think there is a place, number one, a little bit of gun control, but that's my own personal opinion. But the second thing is to actually make sure that we are training, we are practicing so that we get it right and we can save ourselves and each other and the patients.
Yes, very good. I'm a big believer in them practicing too, and with students, I guess it depends on what your setting is, but you said you were in the military, correct? And had that, yeah. Okay. All good. Well, I hope we will leave today with the active shooter drill buzzed into our head, right?
Yes, thank you so much, Dr. Burgess, and thank you again to the Cain family. If we can give Dr. Burgess and the Cains a round of applause.
Okay. Thank you. Thank you very much.
Thank you for being here.
Okay. Bye-bye.